Good morning and happy Saturday, everybody. This is Nurse Eunice with Florida Training Academy. And in today's video, we're going to be helping you learn, understand, and review your EKG or ECG, depending on where you are in our country, rhythms today. So hopefully we'll get started in about 10 seconds. So welcome. I think I saw MFW. Good morning. And then for all of the others who are coming in, I will be monitoring the chat during today's review. So again, thank you for joining us. Right. So in this review, all right, I'll guide you through the essential EKG rhythms that are commonly tested on the NCLEX, or if you're working in the medical profession, and even if you're a CNA, sometimes you want to know what is going on with your patient. What do those rhythms on the heart monitor mean? So our goal is to help you confidently recognize and interpret these critical cardiac rhythms so you're prepared to answer exam questions and be a more competent caregiver. Yes, good morning, Sham. It's like I think it's Anika, Love Freeman, Nikisha, someone whose name I can't read that says hi dear, good morning, and Miriam. So we'll cover everything from normal sinus rhythm to life-threatening arrhythmias, which is an abnormal rhythm, such as ventricular fibrillation. Be sure to have your notes ready as we'll provide tips and practical advice on how to identify each rhythm and understand its clinical significance. Get ready to take your NCLEX prep or your EKG knowledge to the next level. And so I know it is a long link, but I uploaded a free study guide. So probably the easier way to get to it is just go to freecnaprep.com and then it's going to say go to the store. The store has a lot of free digital products, ebook study guides. So you're not buying anything. You just go to the store and select the study guide that you would like. And the study guide for today's video would be the cardiac rhythm study guide. So yes, it's taking you away from our main website, which is fltraining.com, but it's hard to have so many free resources on our regular site. So go to freecnaprep.com to get your downloadables. Question number one, everybody. Which EKG rhythm is characterized by a regular rhythm, a rate of 60 up to 100 beats per minute, and a P wave before every QRS complex? Is it A, atrial fibrillation, B, ventricular tachycardia, C, normal sinus rhythm, or D, asystole? So your normal complex would have a P wave and a QRS complex. So that's your hint. If it's normal, it's going to have a PQRS. So which would be the correct answer for number one? That's right, Imani and Chrissy and Mila. If you all chose C, you are correct. So normal sinus rhythm is defined by a regular heart rate between 60 to 100 beats per minute with a P wave preceding every QRS complex. And so if you have an opportunity to maybe expand this image, you're going to see how everything is tight and right. It just looks normal. There is everything that's spaced at an appropriate space. There's nothing that's going too fast. If this was a 6-second strip, what you'd have to do is you would count the very top of every peak, and that peak is called the R. So if we count the R's for this particular 6-second strip, we have 1, 2, 3, 4, 5, 6, 7, 8 R's or 8 QRS complexes. And what we would do was we would multiply that. If a 6-second strip, we count how many complexes and multiply that by 10. So what would be the heart rate of the person whose rhythm is illustrated here? If we have 8 QRS complexes, and this is a 6-second strip, what would be the heart rate? Let's see what you have in the chat area. And I'll be entering the answer also. Yes, that's a P wave, Mila. So we have a 6-second strip. Yes, Buck. We have 8 QRX complexes. And that would mean everybody who is entering 80 beats per minute is absolutely correct. So if you saw this on a monitor, you wouldn't be too concerned. As long as your patient's responding to you and all is well, this is a good rhythm. This is a normal sinus rhythm. Let's go to question 2. What is the most appropriate initial treatment for a patient with sinus bradycardia and symptomatic hypotension? Because as a nurse, as a caregiver, it's just not important to recognize an abnormal rhythm. We have to know what to do when the rhythm is abnormal. So if someone has symptomatic hypotension with bradycardia, do we administer digoxin? Do we defibrillate the patient? Atropine. Revealing the answer in 3, 2, and if you chose D, administer atropine, you are correct. So now let's look at this rhythm. If this was a 6-second strip, we have PQRS, so we have our entire complex. We only have 4, we multiply that by 10, that means that this person's heart rate would be 40, which would be bradycardia. What makes it sinus? The sinus is because there's a P wave in front of the QRX complex. So when someone has a heart rate of 40, they're going to be dizzy. If we took their blood pressures could be lower than normal, which is what we refer to as being symptomatic. And of course, once you recognize this as the CNA, you call the nurse in the room, and one of the first medications that will be given to this person is going to be used to increase the heart rate in symptomatic bradycardia. However, defibrillation and cardioversion, which were some of the other answer options, are used for other types of arrhythmias. So you would not defibrillate or cardiovert somebody who had a slow heart rate. Question number 3. In atrial fibrillation, what is the primary characteristic seen on the EKG? Atrial fibrillation, is it regular P waves, absent P waves with irregular rhythm? Is it a wide QRX complex, or is it flutter waves? Atrial fibrillation. Whenever I think of atrial fibrillation, I think of somebody who's cold and they're shivering. And because they're shivering, it's a quiver. So the baseline is more of a fibrillation. Number 3, you selected B. You are correct. So it says absent P waves only because you cannot distinguish a P wave. They are not distinguishable. So this is an irregular rhythm that is narrow. And because it's narrow, those QRX complexes are tight, it's narrow. That means it's generating from the top part of the heart, the atrium. So we call it atrial fibrillation. There are no distinct P waves, atrial electrical activity. So what's the clinical significance? If the heart is just quivering and it's not pumping properly, the blood can become stagnant, and stagnant blood causes blood clots. And so when someone has chronic atrial fibrillation, a lot of the times, in addition to being on a medication that's going to controls their rate and their rhythm, they're also going to be on blood thinners, also called anticoagulants. Question number 4. Which of the following rhythms is life-threatening and requires immediate defibrillation? Is it A, sinus tachycardia, B, atrial fibrillation, C, ventricular fibrillation, or D, second-degree heart block? Which requires immediate defibrillation? Looks like Merlan says D. Alabari says C, Miriam D, Elise B, and so Mila says C, Love says C. So we have a lot of correct responses. So whenever you think of defibrillation, I want you to think of ventricular fibrillation. So the term that we use is that we defib for VFib. And so look at those flutter waves, but they're wide and bizarre. So if it's wide, that usually means that the rhythm is being generated from the ventricles, the bottom of the heart. But you don't see those QRS complexes. It's just like they're just quivering. There's nothing distinct. So if you were to take this person's pulse, they wouldn't have a pulse. This would be a rhythm that not only requires defibrillation, it's a shockable rhythm, but it's also a rhythm that requires immediate CPR. So the correct response was C. Ventricular fibrillation is a chaotic rhythm that leads to the absence of a pulse and requires immediate defibrillation plus CPR to restore a normal rhythm, and to also restore perfusion. And when you're performing CPR, don't forget you have to compress 2 inches, and that your goal is to make sure you're perfusing those major organs, which includes the heart, the lung, and the brains. So you're not going to hurt the person by compressing. A lot of us think we're going to compress too deeply, and we're not. 2 inches is sufficient for most average size adults. Question number 5. Which rhythm is commonly described as having a sawtooth appearance on the EKG? Is it atrial fibrillation, atrial flutter, ventricular tachycardia, or sinus bradycardia? Good morning, Monique. A sawtooth appearance on an EKG. Revealing the answer in about 10 seconds. We're going much slower with this review because I want to give you time to process, and if you're utilizing the study guide, to actually look up the information. So Mila, Chrissy, you both say C. Buck and Love say B. So that sawtooth pattern, everybody, would be atrial flutter. And so when you look at the strip, the 6-second strip here, it says that atrial flutter presents with a sawtooth-shaped flutter waves due to rapid, regular atrial contractions. And then to the side, I have a note for you. It's a helpful hint. So whenever you come back and review the video and take your notes, a flutter ratio is the mathematical relationship between the number of flutter waves, so we can't call it P waves, we call it flutter waves, and the number of QRS complexes in atrial flutter. So if you look at this and you were to count it, how many flutter waves, how many sawtooth shapes do you see before the QRS? Is it a 2-to-1 ratio or a 3-to-1 ratio? Go ahead and put it in the comment. So count them out. How many do you see before each QRS complex? Is it a 2-to-1 ratio or a 3-to-1 ratio? Yes, everybody, I am so proud of you. So if you counted the flutter waves for this particular strip, there are 3 flutter waves to every 1 QRS. So if you were explaining this to someone else, if you told us that someone had atrial flutter, we'd ask you what the ratio was, and the ratio would be 3 to 1. How is your patient presenting? Your patient's probably fine. Because if we go ahead and we count it out, their heart rate is 70 beats per minute. So in most instances, this would be something that we monitor, that we notify the doctor of, that we will probably do blood pressures about every hour on this patient. But this patient still has a perfusing rhythm. Even though it's not perfect, we will take what we can get until the cardiologist can come in and see this patient. So atrial flutter is usually benign and it's not a medical emergency. Question number 6. A patient presents with a heart rate of 150 beats per minute and a regular rhythm. The EKG shows narrow QRS complexes and P waves. What is the most likely diagnosis? Is it sinus bradycardia? Now, Brady means slow, and this person has a heart rate of 150. So it's not A. Is it B, atrial flutter? Is it C, ventricular fibrillation? Or is it D, sinus tachycardia? The fact that it said regular and narrow means that it is the rhythm is being produced from the upper part of the heart. So it's not ventricular. What would be the correct response? If it's wide and bizarre, it's ventricular. If it's narrow, it's coming from the atrium. So for this particular question, if you chose yes, D, sinus tachycardia, you are correct. And now I want you all to tell me the rate. Remember, this is a 6-second strip. So I need you to count the QRS complexes and then multiply that number by 10. What would be the rate? And you can't really see the P waves because the heart rate's going so fast, we can't see the P waves on the monitor. Okay, so the correct answer is D while you're telling me what the heart rate is. Sinus tachycardia is characterized by a regular rhythm, which means that all of your complexes march out with the heart rate exceeding 100 beats per minute, often in response to physiological stress. All right, so let me go back and count. Buck says 100, Chrissy says 100. I'm going to count now. Great job. So for this one, the heart rate is 100 beats per minute. Great job. And how do we determine that? Was we counted our R's, the very tip of the QRS complex. We went ahead and we counted them out, and we have 10 of them. For a 6-second strip, you multiply it by 10, whatever number you received, and that's how you get your count for a full minute. Question number 7. What is the hallmark feature of second-degree heart block? An old term was Mobitz type 2. Is it A, progressive prolongation of the PR interval? Is it B, randomly dropped QRX complexes without PR interval changes? Is it C, absent P waves? Or D, chaotic irregular rhythm? So for your heart blocks, we have 4 different heart blocks. We have first degree, we have second degree type 1, second degree type 2, and then third degree heart block is considered a complete heart block. So there are 4 different heart blocks. Right now, I want you to write down the note if you haven't done so that you can get this one right. Second degree heart block type 2 is almost everybody answered it correctly. Yes, it is B, randomly dropped QRX complexes without PR interval changes. So when you look at this strip, we have an arrow pointing up. And that arrow pointing up indicates where there is a P wave that is missing the QRS behind it. And so if you had your calipers and you were able to measure a strip, you would see that for the other how should I say, it's for the other complexes, that the P wave is starting to get further and further. I'm sorry, for this one the P wave is not changing, so the PR interval is the same, but you're still having drop complexes. What would be the clinical manifestation for this one? This person's heart rate on this strip, you would not count the P waves, you'd be counting the QRS complexes. Their heart rate's 50. So even though this appears to be a little bit faster than some of the other rhythms, because they are dropping complexes, remember, if there's not a QRS, that means that the heart didn't contract, it didn't pump any blood out. So P waves do not produce contractions. So this person's heart rate is 50. How do you think a person would feel if their heart rate was 50? They'd be weak, they'd probably be lightheaded. So this would be something where a person would more than likely be symptomatic. And so rationale: type 2 block is characterized by sudden drops, which can lead to more serious heart blocks. And now in the red, I have second degree AV block is a form of an incomplete heart block in which some, but not all, atrial beats are blocked before reaching the ventricles. You want to make someone aware of this right away. So if you're the CNA, you'd be, of course, notifying the nurse. If you're the nurse, you're notifying the doctor, because this could progress to third degree heart block. Question number 8. Which of the following EKG rhythms is characterized by an absent heart rate and is considered a flat line? Think of all the TV shows you've seen. Is it A, asystole? Is it B, ventricular tachycardia? Is it C, atrial fibrillation? Or is it D, sinus bradycardia? Which one is considered a flat line? Buck, you are rocking it today. Yes, Buck and Imani. Yes. So I'm going to go ahead and reveal the answer. The correct response is A, asystole. Asystole represents the absence of any electrical activity, indicating that the heart has stopped beating. A being absent. Remember prefix, if it has a or an in front of a term, that means the lack of. And so whenever someone, if you see this on the monitor, you're going to call for help, you're going to assess your patient, you get 10 seconds. That's all you get to check for a pulse and to check for breathing. And you lower that head of the bed, hit the CPR mode on the bed if you're in the hospital, and you start doing those high quality chest compressions immediately until your team can come in with the crash cart, the backboard, etc. So asystole is a deadly rhythm, okay? Question number 9. What rhythm displays a wide QRS complex with no preceding P waves and a rate of 100 or more beats per minute? So as soon as it said QRS complexes, I expect for it to be wide. And then it said that it was greater than 100 beats per minute. So it's that Brady, sinus, or tachy. With that in mind, is the answer A, atrial fibrillation, B, ventricular tachycardia, C, sinus tachycardia, or D, first degree heart block? So, Mila, yes, we can save a person's life when they are if they have a systole, if their heart rate, it's just that as a CNA, it's going to be harder because we need to first start our CPR. A systole is not a shockable heart rhythm. So we need to figure out those H's and those T's. For a systole, all we can pretty much do is high quality CPR, start an IV, give drugs, and try to reverse the reason for this person's cardiac arrest. For example, if the person was wounded, let's say they bled out, they hemorrhaged, there's nothing we can do except for get some blood into their body, get some fluids into their body, and then try to stop the bleeding. So not all of these arrhythmias are from cardiac reasons. It's some external forces that could have actually taken place, some traumas. And so, yes, a person who has who is in a systole, they are least likely to survive. But if they have a good medical team, and if we can actually fix whatever caused their cardiac arrest, then hopefully their chances of survival will improve. All right, so let's go ahead and show the correct answer for question number 9. Question number 9, if you chose B, ventricular tachycardia, you are absolutely correct. So the rationale, ventricular tachycardia originates in the ventricles and produces wide QRS complexes at a fast rate, often with no visible P waves. So I'm on the cardiology unit, young nurse. I see this on my patient's monitor. My patient's talking to me, you all. So I run out and I call the doctor and I'm like, hey, doctor, such and such. The patient had a 20 beat run of VTAC. And you know what the doctor said to me? What else? So just because you see this on the monitor, it doesn't mean your patient is critical. It means that you do need to notify the doctor. But when you notify the doctor, you need to be notifying them with more than just the person has VTAC. How is the person presenting? What is their blood pressure? Did their mental status change? Did their medications change? So just seeing this on the monitor doesn't mean that there's a medical emergency. Remember, we don't treat monitors, we treat people. So when you see this, go and look at your patient. Okay. Any questions about ventricular tachycardia? All right, question number 10. Which of the following interventions is appropriate for a patient in ventricular fibrillation? Is it A, synchronized cardioversion, B, administer atropine, C, CPR and defibrillation, or D, pacemaker insertion? And then, Buck, I want to go back to you. I'm so proud of you being in your PCT course because you are rocking these questions. You're getting all of the answers right. And also, Imani, you're doing a great job too. And if I haven't called out your name, I will start looking at the others and seeing what your responses are. So, looks like Elise says C. Any other responses? Chrissy says C. Nichelle says C. So great job, ladies. And Maria says C. So great job. If a patient has ventricular fibrillation, remember that doesn't produce any contractions. There will not be a pulse. So the correct response is C. You need to start high quality CPR. And of course, when that crash cart gets there, we're going to defibrillate. Ventricular fibrillation is a medical emergency that requires immediate CPR and defibrillation to circulate blood and to restore a viable heart rhythm. So now we're back to our rhythms. What rhythm is identified by a progressive prolongation of the PR interval until a QRS complex is dropped? Is it A, first degree heart block, B, second degree heart block type 1? We used to refer to it as Winky Bach. C, third degree heart block, or D, atrial fibrillation? Right, giving you a few seconds to put your responses in the comment, and then I will answer Myla's question. I see A, B, C. I see some more A's. And I want you to write a note because if we are dropping QRS complexes, it's not A. If we're dropping QRS complexes, it is going to be B. So the correct response is going to be second degree heart block type 1. And the rationale is Winky Bach. The Winky Bach block is characterized by the gradual prolongation of the PR interval until a PRS complex is dropped. And so if you look at the markers, remember if you're doing this in real time, you'd have your calipers and you'd be able to go ahead and measure from the start of the P until the R. So the R is the downward deflection before it rises up, going towards the QRS complex. And let's see, I see some other questions there. And so if you look at the first complex, it says wide, right? And then when you go to your second complex, the distance from the P wave to the QRS gets wider. And by the time you get to about your fourth complex, you have now dropped. So wide, wider, drop. Now you have Winky Bach is a rhyme that helps you remember the characteristics of second degree AV block type 1, also known as the Winky Bach phenomenon. So for second degree type 1, the PR interval gets longer and longer until a complex is dropped. For second degree type 2, the PR interval is unchanged. It remains the same, but you're still dropping QRS complexes. And let me go back and answer Mila's question. So Mila had a question, everybody. All right, and so Mila wants to know what is the difference between cardioversion and defibrillation. So even though the device, when we call for the crash cart, the defibrillator has multiple modes. And so one of the modes is cardioversion. Cardioversion is what is used, and we put a term in front of it called synchronized. Synchronized cardioversion is what we use to slow down someone's heart rate when they still have a pulse and the heart rate is fast. So this person is more likely still talking to you. So we're going to use less energy and we're going to sync it so that it hits whenever the shock hits, it hits on the very tip of the QRS complex. And the person, whenever they get shocked, it's going to help slow down their heart rate. So when you think of synchronized cardioversion, think of someone who's still alive, who needs energy to reset their heart, but not so much energy. Defibrillation is, I hate to say, the dead man's dose of energy. So defibrillation means that we're just going to shock them indiscriminately. We're not going to sync it. And that requires more energy. So this person's not alive. They do not have a pulse. They're in cardiac arrest. And so sometimes the differences in the joules, the dosages would be for cardioversion. We'll start from maybe 120. But for 120 joules, that is. But for cardioversion, we're sometimes starting off at 200 joules, and sometimes they go up to 300 joules. So you're giving this person a whole bunch of energy to try to restart their heart. So I hope that helps you to understand the differences between cardioversion and defibrillation. All right, question number 12. Which of the following is the treatment for a patient in asystole? And everyone should get this right. Asystole is the lack of energy. So it cannot be treated with energy. They don't have a rhythm. So is it A, defibrillation, B, cardioversion, C, chest compressions and epinephrine, or D, administration of digoxin? And I'll give you 10 seconds before I reveal the answer. Remember, asystole, they don't have any energy. So we can't shock something to get something that wasn't there. So you would not defibrillate asystole. So I see a lot of correct answers. If you chose C, great job. It is chest compressions and epinephrine. Right now, all we can do is keep circulating that blood, and someone needs to be on that chest doing chest compressions. Otherwise, when we give the medication, it's just sitting in the vein. So when they're doing that chest compressions, they are externally causing that person's heart to beat. And now that gives us time to figure out what caused the arrest. As I said before, if it's due to trauma and they bled out, that would be hypovolemia. We would have to, of course, trauma. We're going to put a whole bunch of blood into them, a whole bunch of fluids, and then try to get them to surgery to stop the bleeding. Question number 13. Which EKG rhythm is characterized by an irregular rhythm with no distinct P waves and irregular R to R interval? So let me read this again. Which EKG rhythm is characterized by an irregular rhythm with no distinct P waves? So it didn't say no P waves, it says no distinct P waves and irregular R to R intervals. Is it A, atrial fibrillation, B, sinus tachycardia, C, ventricular tachycardia, or D, sinus bradycardia? Think back to those rhythms that we saw earlier. Which one had no distinct P waves? It was irregular. Let's see if I see any correct responses. Revealing the answer in 3, 2, and here we go, everybody. If you chose A, atrial fibrillation, you have the correct response. So when you look at this rhythm, look at that quivering baseline. You can't see a P wave. You just see a whole bunch of quivers, fibrillation, and then you see a QRS complex. But if you used your calipers and you were to march them out, you would see that the distances from QRS complex to the next QRS complex, it varies, so it is irregular. So this is a classic strip for atrial fibrillation. And so again, the answer is A. And atrial fibrillation, if you're writing down your notes, it has a quivering baseline, a narrow QRS complex, so they're still tight, which means that the rhythm it starts off in the atrium, not in the ventricles. And then on top of that, the QRX complexes are not regular, they are irregular. Question number 14. A wide and bizarre QRX complex. So if it's wide and bizarre, that means that it's generating, is it from the atrium or from the ventricles? If it's wide and bizarre. So let's go back and read this one again. A wide and bizarre QRS complex occurring early and followed by a compensatory pause is most indicative of, this is something new, we haven't talked about this. So is it atrial flutter, sinus bradycardia, premature ventricular contraction, or asystole? So I gave you a good hint. I highlighted the word early and told you it was something we hadn't discussed yet. That's right, everybody. And it's okay to be wrong, Mila. We're learning this together. All right, so my Buck and my Chrissy, you all are correct. The answer is C, premature. Remember, I highlighted the word early. So premature ventricular contractions. And so whether it's going upward, we'll say upward or downward deflection, just depends on the leads. How are they placed on the patient's chest? And so, or what settings you have on your monitor. So the rationale, PVCs are characterized by early, wide, and abnormal complexes with a compensatory pause. So when we say early, what are we talking about? Remember that the QRS complex is supposed to come after the P. But if the QRS comes before the P, and there's a compensatory pause, not only is this abnormal because it actually came from the ventricles, but it came before the normal complex, and it makes things go out of sync. And so a PVC, if you only have a few, that's the heart's a little bit irritated. The patient's going to be fine. They should be okay. But if you start seeing more and more PVCs, it could be a sign that their labs are abnormal, that their medications may not be therapeutic. And so you would want to, if you're a CNA, notify your nurse. If you're a nurse, you want to, of course, call the doctor, who will then order a 12-lead EKG. But a PVC every now and then, your patient more than likely would not have any symptoms. Question number 15. What is the treatment of choice for a stable patient with atrial flutter? Is it A, defibrillation, B, CPR, C, beta blockers, or D, pacemaker insertion. Remember atrial flutter, the sawtooth? So it had the sawtooth patterns, but nothing was dropping. The heart rate was usually greater than 60. It didn't appear to be a lethal arrhythmia. So, what would be the intervention for someone who had atrial flutter? Yes, it is C, beta blockers. So we call those the LOLs because the medications all end in lows. So beta blockers are commonly used to control heart rate in patients with atrial flutter. And so common beta blockers are atenolol, labetalol, metoprolol. So your beta blockers end in LOLs, and they are given for two reasons. Number one would be rate control, and then another reason would be for blood pressure. Question number 16. A patient presents with a regular rhythm. That means there's a P wave. When we say regular, that means a P wave is there. The heart rate is 45 beats per minute and a P wave before each QRS complex. What is the rhythm? Is it A, sinus bradycardia, B, sinus tachycardia, C, ventricular tachycardia, or D, atrial fibrillation? I think everyone's going to get this one right. Yes, Jimmalyn. Yes, Emily, Chrissy, Imani, you all have it. So, heart rate of 45 and P waves that are there with the QRS complexes means that that rhythm would be sinus bradycardia. So, the answer is A. Sinus bradycardia is a slow but regular rhythm with a rate less than 60 beats per minute. And so I want you all to go ahead and count the QRS complexes and then multiply the number that you have by 10 and tell me this patient's heart rate. And we'll give you about 15 seconds to do so. So remember, you want to count the QRS complex, the very tip. Tell me how many you counted, and then whatever you count, multiply it by 10, and that would be the count for 1 full minute. And yes, for this one, so it's not the dark black lines. I think it's Chindinma. It is the QRX complex, it's the very peak. And so there are only 4 present. So that means that this patient's heart rate is approximately 40 beats per minute. Understood it was delayed. Yeah. Thank you for telling me. All right. Question number 17. What EKG rhythm is characterized by a complete dissociation between atrial and ventricular activity? Is it A, first degree heart block, B, atrial fibrillation, C, third degree heart block, or D, sinus bradycardia? So we're back to if there is a complete dissociation. So the atrial, the top part of the heart is doing its own thing, and then the bottom part of the heart is doing its own thing, and they're not in sync. And so this could be quite lethal. The person still has a pulse right now, but we need to get them seen by a cardiologist as soon as possible because this can progress to an even more lethal arrhythmia. So that is my hint. Which of these would be the worst rhythm before someone goes into asystole or ventricular fibrillation? Great job, everybody. Everybody chose C, third degree heart block. And so, whenever I think of a third degree heart block, in my mind, I literally see people dancing to 2 different rhythms. And so, here for the P waves, I have somebody who's breakdancing. And the breakdancer is just dancing at his own pace. There is nothing dropping If you had your calipers and you march them out, your P to P intervals will be all the same. But look at our ventricles. Look at those wide and bizarre QRS complexes. That's a ballerina. She's going a little bit slower today. She's just taking her time doing her dance. If you were to count this person's heart rate, you would not be counting those P waves because those P waves did not produce a contraction. If it produced a contraction, you would see a QRS behind the P wave. So for this one, the ventricles are doing their own thing. They're firing, but they're firing really slow. So there is no association. The QRS complexes are sometimes before the P waves, nothing's dropping. You all tell me what would be this person's heart rate. Would you be counting the P's or would you be counting the QRSs? And I'll give you about 15 seconds to put this heart rate into the comment area. So the P waves are doing their own thing. The QRS, they're doing their own thing. Nothing's dropping, but the person has a slow heart rate. So if you chose 1, 2, 3, 4, if you chose 40 as the heart rate, you are correct. Okay, so again, nothing's dropping. The P's are marching out. The P to P interval will be the same. The R to R interval will be the same, but your QRSs are coming anytime they want, whether it's before a P, directly on top of a P, it doesn't matter. So that will be a complete heart block, which if we don't get this person taken care of, they would go into a more lethal arrhythmia, such as a systole or ventricular fibrillation. All right, so question 18. Which medication is used to treat Torsades de points? And that would be the twisting of the QRS complexes. And I'll show you an image of it on the next slide. Whenever someone has a twisting of their QRS complexes, would you give them magnesium sulfate, amiodarone, atropine, or adenosine? And I know for a lot of you all, these medications are new, so any answer you give me is fine. I just want you to be learning some new content, and we're getting you ready to be nurses. And I'll reveal the answer in 5 seconds. So if you ever see twisting of the QRS complexes, so they're not all originating from the same site within the heart, it's twisting, it looks confused. That is usually because the person has a low magnesium level. And so we would have to do we would give them magnesium sulfate intravenously. And so mag sulfate is the treatment of choice for Torsades de points or twisting of QRS complexes, a type of poly. Remember poly being many, morphic ventricular tachycardia. So this tachycardia is generated from multiple spots within the bottom of the heart where the ventricles are. Question 19. What is the most significant danger of atrial fibrillation if left untreated? So remember, the heart's just quivering. If it's quivering, blood can become stagnant. So is it A, heart block, B, stroke, C, hypotension, or D, asystole? All right, I see Gemma Lynn, I see Elise, I see Mila's answer, Chrissy, Merlon, Buck. All right, so we're going to reveal the answer in 5 seconds. 5, 4, 3, 2, and I'm so proud of you all. Great job. So if the blood becomes stagnant, the person is more likely to develop blood clots. And when those clots travel, one could travel to the brain and the person could have a stroke. So the correct response is B, stroke. Atrial fibrillation can lead to thrombus formation in the atria, increasing the risk of stroke. And when you look at the image, it shows you, hey, the clot has started off in the heart and now it travels. That's number 2. And then number 3 is actually going to block an artery in the brain. And that's when the person can have stroke-like symptoms. Question 20, and I'm so proud of you all for staying on this long. I know this is new content. This is not the fun content. It's not rapid paced. We don't want to rush this. We want you to understand what you're looking at so you can better help your patients. So question number 20, which EKG rhythm is most commonly associated with hypokalemia? Before we go any further, when we say hypokalemia, what are we referring to? Put it in the chat. Hypo means low, but what does kalemia mean? What is it referring to? And I see you all are giving me answers, but I still want to know what hypokalemia means. Does anyone want to tell me? Ah, got you researching. All right. So, which EKG rhythm is commonly associated with hypokalemia? Is it A, ventricular tachycardia? I know, but no one put in a response. Is it B, asystole? Is it C, sinus bradycardia? Or is it D, atrial flutter? Revealing the answer in 3, 2, and so, for you all, when we say hypokalemia, we're referring to potassium. And so, ventricular tachycardia is something that can happen when a person has low potassium. So, hypokalemia is known to, hypokalemia is known to increase the risk of ventricular arrhythmias such as ventricular tachycardia. When you look at the image, when someone has low potassium levels, of course, they can have muscle cramps. That's like the number one thing. When someone says, oh, my leg is cramping, we tell them to go eat a banana. All right, so if the potassium is high or low, the person can have cardiac issues. So that's why we're always monitoring their labs. So with low potassium, it can be muscle cramps, it could be weakness, they can become fatigued. Yes, they can become paralyzed. Your muscle, the heart is a muscle. The muscle needs potassium. So if you don't have any potassium, you're not moving too far. They can become constipated, they can have respiratory failure, and then, of course, they can have arrhythmias. Yes, Patel. All right, great job. Question 21. Which heart block typically does not require immediate treatment unless symptomatic? So let's go to those 4 heart blocks again. We have first degree heart block, which we've not covered yet. We had second degree heart block type 1, second degree heart block type 2, and we had a third degree heart block. So when you're thinking of your heart blocks, which one is usually not as medically complex? Which one doesn't really require a whole bunch of medical treatment? Is it going to be A, ventricular fibrillation, B, second degree heart block type 2, C, third degree heart block, or D, first degree heart block? So when you're learning your heart blocks, they have the degrees. Remember, third degree was complete heart block. That's an emergency. Second degree, we're kind of monitoring the patient. First degree, usually your patient is asymptomatic. So they're not dropping any QRS complexes. The heart rate is still normal. It's just that it's taking longer For the P2 QRS, the PR interval, is just taking longer to conduct, and that could be because of medications. And so the correct response is D, first degree heart block. It usually has a prolonged PR interval, but it's benign. It's just something we monitor, and it often does not require any treatment. So hopefully you've learned the four blocks today. We have first degree, we have second degree type 1, second degree type 2, and third degree heart block. And if you need to go back and just look at those again, don't forget we have the free study guide, and on top of that, you can go back and replay this video. Question 22, which rhythm requires immediate CPR and defibrillation? Is it A, sinus bradycardia, B, asystole, C, ventricular fibrillation, or D, atrial fibrillation? I'm crossing my fingers. I hope that you all remembered that one of those means the lack of any electrical activity. And if they don't have electrical activity, we can't shock it. So, which one is the correct response for 22? Is it A, B, C, or D? So looks like Buck, Celia, Rylas. I think I missed somebody. If you said C, you are correct. And so something that I want you to write down, if you haven't written this down yet, is that we defib, aka defibrillate, for VFib. We cannot shock asystole. And if I'm not mistaken, the other rhythms were all perfusing rhythms. So sinus bradycardia, you wouldn't want to shock somebody who still has a pulse. So sinus bradycardia, the heart is still pumping. It's just pumping slowly. You also wouldn't want to shock D, atrial fibrillation. The person still has a pulse. The P waves are variable. It's kind of hard to distinct, but they still have a pulse for AFib. They still have a pulse for sinus bradycardia. A lot of you all knew not to choose B, asystole, because we can't shock something when there is no energy. The correct response is going to be C, ventricular fibrillation, because it is a life-threatening emergency requiring CPR and defibrillation. So the heart is quivering. We need to shock it to restore its normal rhythm. Question 23. What rhythm shows irregular R to R intervals, the absence of P waves, and a wavy baseline? All of you are going to get this right. I know it. Is it A, atrial flutter, B, sinus bradycardia, C, atrial fibrillation, or D, ventricular tachycardia? They said a wavy baseline, and they said irregular R to Rs. Revealing the answer in 10 seconds. 10, 9, 8. It can't be B because it said the absence of P waves. When you see the word sinus, that means that there is a visible P wave there. And bradycardia usually is not irregular. Sinus, that's usually a regular rhythm. So it's not B. Give me another response, everybody. Let's see if someone gave it to me. Revealing the answer now. Yes, love, it is C, atrial fibrillation. So remember, with atrial fibrillation, it has the wavy or the fibrillating baseline. And your R to R intervals, that top of that QRS complex, if you were to march them out with your calipers, they are irregular. They keep moving. They're just doing their own little dance. And so reason why it said no P waves is because you can't see any distinguishable P waves because of that wavy baseline. Question 24. In which rhythm would you expect to see a prolonged PR interval but no dropped beats? Is it A, second degree heart block, B, first degree heart block, C, atrial fibrillation, or D, third degree heart block? And I am so proud of you all just for taking the time on a Saturday morning and even thinking about studying EKGs. Who does that besides us? And everybody is getting it correct. So, yes, question 24, the answer is B, first degree heart block. So, the first degree heart block is defined by a prolonged PR interval without any drop beats. It's just taking slower for it to get to the QRS, just taking its time. That's usually due to medication. And if you counted those QRS complexes, that person still has a normal heart rate, which is usually greater than 60 beats per minute. Question 25. Which EKG findings suggest hyperkalemia? Now you know what kalemia means. You all should know what this means. So, which one suggests the person has too much potassium in their body? Is it A, peaked T waves? Is it B, inverted P waves? Is it C, flattened T waves? Or D, shortened PR interval? I know all this is new material, but I see some of the correct answers, and most of you all have the correct answer. So if you chose A, those peaked T waves, look how far they are above the baseline. The T wave is almost as high as the QRS complex. So if you see something on the monitor and that T wave, the wave after the QRS complex, sometimes will have an S, you will sometimes have a T, but not all the time. But if they're spiked or if they're high, it could mean either one of two things, that they have elevated potassium levels or that they are having a STEMI. So anytime you see that and it's irregular on the monitor and it's elevated, make sure you notify your nurse, or if you are a nurse, make sure you call that doctor to get that 12 lead in right away. And they're usually going to ask for a 12 lead and some labs because we need to figure out whether or not it's from the actual heart or if it's from low potassium levels. And so for you all, what I want to remind you of is that I want you to go back and take this test again after you have actually downloaded your free study guide. I promise that if you take this again after you have actually printed the study guide, or if you just have it available, that you are going to be so much more knowledgeable of your EKG rhythms. And again, I know you may not really need to know this right now if you're not in nursing school, but a lot of my CNAs and PCTs also want to be EKG techs. And so this is going to help you get to that next level. So to download your free study guide, you go to that long website, or you can just go to freecnaprep.com and then go to the store or go to shop. Remember, it's free. And then go back and take this test again and let me know if you do better. And I know that you will. And I have enjoyed spending time with you all today. You all are my favorite students. I love you. Of course, I have students here in Jacksonville, but no one's in the office today. So you all are my favorite students today here on the live, and I appreciate you all so much. And I'm staying around to see what questions or comments that you all have, and I'll go back and review them now. All right, so Miss Excellent, you are so welcome. And Serafina, you're so welcome. Celia said, this is a learning and helpful session for me. Thank you. Yes, go back and look at it again. Buck, you did great. I'm so proud of you. Chrissy, also. Elise, you are wonderful. Rylas, I don't know if we've interacted before, but welcome to the channel. And then Chindema, your name sounds familiar, so welcome back. And then Michelle, welcome back. And so I love you too. Chindema. So I think on Monday, we're going to be doing CNA. We're going to do a CPR video on Monday. And then Saskia will be interpreting a CNA video from English to Haitian Creole or vice versa. And I will be back on, I promise you all next weekend that we'll be doing our live via Zoom. And so I'll be working on getting that scheduled, and we'll do one in the morning and then one in the evening so that I can actually hear you all and see your faces. So just be looking at our community links, whether you're on youtube.com/Eunice Mathis or youtube.com/Florida Training. Go to our community tab, and then hopefully we'll see you on live and hear your voice next weekend. All right, everybody. I love you. Enjoy the rest of your weekend.